Thank you everyone for coming. So for those of you who don't know me, I'm Mary Williams. I am Clinical Director for Frailty and Acute Medicine here in Fife. And we're very pleased to welcome our colleagues from Guy's and St Thomas in London. So Professor Jagdeep Desi and Dr. Jude Partridge are experts in POPs, which is perioperative medicine for older people undergoing surgery. So they come here today to visit us because in Fife we're starting a bit of work in POPs, developing our services here in Fife. And we have lots to do, and they're coming to tell us all about it. So Jagdeep is the BGS president and has been since November 24. And between Jagdeep and Jude, they have published widely on POPs and are really the world experts. So we're really lucky to have them. So I will let them start their presentation. Thank you.
Thanks very much, Mary, and thanks very much everyone for inviting us here. So what we're going to do with a mixed audience is just spend the next couple of minutes looking at how we've tried to develop services tailored to the needs of our changing surgical population, kind of using data and research to help us build up services to make sure that what we're doing is giving value for the taxpayer and providing good quality patient care. And of course, we know that in our current climate, we see changes in the demography of our population. So you see at the top of the slide there, what used to be a traditional population pyramid with lots of young people and just a few people surviving into older age. And so that's from the early 1900s. And then you see at the bottom right of that infographic how that has changed. And it's not really a
Yeah, I don't know why that.
That's weird.
Yeah, weird, yeah.
diabetes. She's slightly anemic and she's noticed that she's a little bit slower and a bit more breathless, can't really do what she could do before, but she thought that was just part of normal aging. And someone like Morag may well be presenting for a colorectal surgical procedure. She might be presenting to the orthopedic surgeons for a hip replacement, or indeed as an emergency through our front doors and our emergency surgical pathways. Sorry. And of course, Morag illustrates through this some of the determinants of health that we know come from our socioeconomic backgrounds. And from the CMO's report, we see, unfortunately, that this older population are frequently living with poverty, whether we're talking about financial poverty or digital poverty. We know that although traditionally we've worried about malnutrition in the older population, it is still an issue. Actually, far more of our patients are living with obesity or are overweight. We have significant amount of sedentary lifestyle in these older patients, and there's a degree of social isolation. We see also from Morag that she's living with multimorbidity, so that's nice to find that as 2 or more comorbid conditions. And you see from the blue graph there, unsurprisingly, the older you get, the more diseases you've accumulated. And then from the other graph there, we also then dish out more medicines. So polypharmacy increases as age and multimorbidity increase. We hear frailty talked about frequently, and compared to 20 years ago or so when we started up the POP service at Guy's and St Thomas's, and frailty was a relatively unrecognised term both in common parlance and in the literature, we now have definitions being made through the British Geriatric Society at the moment. And we see that lots of the criteria that Morag might have noticed when she pitched up for her surgery, so I'm a bit slower, can't really do those things as well, I just feel a bit washed out and exhausted, she might perceive that as normal aging, but actually we know from Linda Freed's work in that yellow box, they were the criteria which defined frailty when it was first described back in 2001. But we also know that there's a degree of cognitive impairment in these older patients presenting for surgery. So quite sobering statistics here that actually, although we do see patients presenting with dementia and we do recognise delirium in our patients after surgery, actually a lot of this disease is not well recognised, and patients may be presenting, and we are missing in those clinical encounters the fact that these patients are now living with a life-limiting condition, dementia, which is now the biggest cause of death in the UK. And this isn't just an isolated case example. It's not just Morag that's living in this way. We know from the SNAP-3 studies, which many of you may have seen published recently in the British Journal of Anaesthesia, that this is exactly what we see when we look at a heterogeneous group of patients undergoing surgery across all 4 nations of the UK. So 1 in 5 of them are living with frailty, 2/3 of them are living with multimorbidity. This infographic here shows that 1 in 30 of them did not have the mental capacity to consent to the SNAP-3 study. So some of that burden of undiagnosed cognitive impairment that we were talking about. And here is this point about BMI going up as people age, and that malnutrition is not just a problem in older people, but actually the impacts of being overweight or obese. So what can happen to Morag when she comes through our services? Well, perhaps it's all a bit fast for her. She doesn't really understand the way we're communicating things. She's got sensory impairments. She might be health fairly illiterate, and she thinks this all sounds awful, this operation. I don't think I want this, and she turns surgery down. Perhaps someone recognises she's got all this medical pathology and they send her off to an anaemia clinic, a chest physician, a cardiologist, a diabetologist. Go and see all these doctors, see your GP about your hypertension. They'll make you better for your surgery. But she gets lost navigating this complicated pathway with multiple touch points with different doctors, all of which incurs a cost for her and, of course, a financial cost. Or perhaps she turns up, but she's cancelled on the day of surgery. We don't like the look of her breathlessness. We think perhaps it isn't a good idea to give her an anaesthetic for a procedure when it hasn't been investigated properly. Or maybe none of those things happen. Maybe she comes in and she gets excellent care. So we look after her on an enhanced recovery programme. She appropriately goes to level 2 or 3 if she needs it post-operatively. And she's even had prehabilitation, so she was totally prepared for this. But unfortunately, we know that when you step down from critical care, this still commonly happens on the wards where we work. So she might have been fine throughout the critical care stay, but actually we haven't quite got her analgesia right. She's on and off different opiates with opiate-related complications. Her diabetes isn't very competently managed and on and off a variable rate insulin infusion. She's got lots and lots of fluid going in, which is resulting in hemodilution, so she's anemic now. Someone wants to give her blood. One medical registrar says you're overloaded, so they give her frusemide. The next one says, no, you're not, you're dry, and they fill her up a little bit more. Throughout all of this, she's progressively withdrawn. She's not really interacting, but she's not causing problem at night or trying to leave the ward, so we completely miss her delirium. Someone thinks she's depressed and they give her an antidepressant. And poor Morag leaves with carers after an elective surgical procedure, when some of this perhaps could have been done better or anticipated. And again, that isn't just an isolated anecdotal case example. That's exactly what we saw from the SNAP-3 data. So you can see just some of the headlines there, that frailty is strongly associated with complications on the ward, with delirium, with staying in hospital for longer, and with a greater chance that someone's died at 12 months. We see that multimorbidity was also associated with complications on the ward. But interestingly, once someone's living with frailty in the modelling in SNAP3, the addition of multimorbidity didn't make much difference. So the take home here, when we're starting to establish services and look at where we can get most bang for our buck early, is to look at frail patients and see if we can be intervening there. And of course, there's great costs to these kinds of examples that we see all the time on the ward. And there's great costs for Morag, but there's also great financial costs for our institutions and in terms of informal costs, so families providing care, taking time off work and other things like that. So we know all these things about us. We know from studies that ill people die. We know that frail people do badly. We know that it can't be good to collect up diseases and not walk as fast as our peers. And to be honest, we think we need to stop doing studies telling us that ill people die, and we need to start doing something about it. Even though we might not have a perfect solution, we've got to do something when we see that every day we're looking at patients presenting with these kinds of issues. And of course, most of us are quite motivated, and we sort of think we know what might make good perioperative care. Certainly our patients are very consistent, doesn't matter where we're working in medical or surgical services, that they want joined up care. They want to understand what's going to happen to them. They do not want to be navigating numerous different hospital departments, phone numbers, pathways, forms. And certainly that's also what we want as health professionals, because we know it's more satisfying and it provides quality care, but it's also cheaper healthcare, and therefore we can deliver better and more equitable care to all. So as geriatricians, we've been using this methodology called comprehensive geriatric assessment and optimization for a number of years now across whichever situation we find ourselves in looking after patients. So you can do this in ED at the front door, we can do this on a medical ward, you can do this in a care home. And at Guy's and St Thomas's, as we've developed the POP service, what we've been doing is embedding this evidence-based methodology into the surgical setting. You can see a definition at the bottom there that just tells you what CGA is. But essentially, it's a holistic look at a patient and then employing the evidence base we have to try and do something about the problems which you're identifying. And that's the methodology that we've embedded into our model of care at Guy's and St Thomas's, whether we're talking about elective patients, as you see on the left of the slide there, or whether we're talking about emergency patients. And of course, things are time-tailored to the acuity of the surgical presentation. But essentially, we use screening, we use a holistic assessment, and we use evidence-based medicine tailored to that patient to try and optimise them before a surgical procedure, and then feed into the process of shared decision-making with our patients. And that all sounds okay, doesn't it? But what actually happens when you do a CGA? What are we actually doing? So this work was done by a couple of our fellows a few years ago, and they looked at 500 patients coming through our elective outpatient CGA-based POP clinic. So these were patients presenting to surgeons from all different surgical specialties. So we cover all surgical specialties at Guy's and St Thomas's with the exception of neurosurgery. So patients coming for plastics, breast, orthopedics, urology, vascular, etc. And what you see here is that when they came to our clinic, 2/3 of these patients received a new diagnosis. So that would be things like patients thinking it's just normal to cough and be breathless. It's just normal to be breathless with swollen ankles, or it's just normal that I'm falling over all the time. But actually, we're diagnosing COPD or decompensated heart failure. And then we're doing something about it. So 3/4 of these patients then had their medicines managed. And that wasn't cessation of a DOAC before surgery or cessation of clopidogrel. Rather, that was management of a long-term condition which had been identified. You see here that there's quite a bit of sort of trying to guesstimate and predict what will happen to people and giving ward teams clear examples of how to manage post-operative AF, how to use deep breathing techniques to get people out of bed and minimise the chance of them having pneumonia. A little bit of investigating and liaison, obviously, with anaesthetic colleagues where appropriate. And then 1 in 10 patients, actually, we're realising that they're towards the end of their lives. And actually, we're doing anticipatory care planning, discussing do not resuscitate, and what do those patients want in terms of their preferred place of care at the end of their life in that outpatient setting. 1 in 3 patients go on to be referred to other clinics, so PD clinics if we've diagnosed PD or they've got very nasty COPD and they need to go and see a respiratory physician for the longer term. And then 98% of patients have a shared decision-making conversation recorded. I don't know what happened to the 2% who didn't. So briefly on shared decision making, we know that this is a national standard, and regardless of which situation we're working in, every patient should be undergoing shared decision making about all healthcare decisions. Within our service, about 1 in 7 patients after shared decision making didn't proceed with the surgical procedure which was initially being considered. We actually saw that when we looked at this nationally from this piece of work here, some of our fellows did, that actually it was higher, about 1 in 4 not undergoing the original surgical procedure when you looked at 7 other POPs services across the country. And then within our vascular pathway, we took the opportunity of COVID to try and reorganise the way we saw elective aneurysm patients. So they saw us in the POPs clinic, and then we had an MDT with the vascular surgeons, anaesthetists, and us from POPs to then look at realistic choice for those patients and then undertake shared decision making with them. And we found that actually 1 in 4 patients chose not to have surgery after that process. When we looked at what happened to those patients at 12 months, there was obviously a reasonable mortality rate in them. But actually, what you see at the bottom of the slide there is that nearly 3/4 of them were dying from a non-aneurysm cause. So these were patients that when we compared it to our data from several years ago, actually would have had an expensive aortic graft put in with all the consequence of a surgical procedure, both in terms of cost and for them as a person. And actually they were dying of frailty or medical related conditions at the end of 12 months anyway. So no extension to longevity, and it may well have been a more complicated time for them. So does it work? So we've tried to look at the evidence base behind this over the years. So this is work in elective orthopedics from right at the start of our service. This is looking at urology surgery. And then this is some work in vascular surgical patients with aortic aneurysms and lower limb occlusions, showing that when you undergo this process of CGA in comparison to standard care or standard care at Guy's and St Thomas's, you see fewer medical complications. Interestingly, we actually saw fewer surgical complications as well, and that you see a 40% reduction in the time that patients are spending in hospital. We've looked at trying to replicate this work across different services in all 4 nations, and certainly in hospitals that are not like Guy's and St Thomas's, so district general hospitals with far different populations or that have workforce issues and other types of trusts. We've looked at the big data, so using things like NHFD and NELA or the Scottish equivalent, and found that actually touch points with a geriatrician, even during admissions for things like emergency laparotomy, are driving down 30-day mortality rates. And then importantly, we've looked at cost, because it's all very well to have a service which might be nice for patients or that we think might make things better. But if it's too expensive for our trusts and our hospitals to fund, there's no point, because we're not going to be able to roll these things out. So this looks at 2 health economic analyses, this slide. So the first one was looking at our randomised controlled trial in vascular patients and showing that there is just over £1,000 cost saving per patient for the patients that went through the POPs pathway as opposed to our standard of care at the time. And that's predominantly driven by a shorter length of stay. And then this was looking at that reorganisation of the aortic aneurysm pathway that we undertook following COVID, and showing that if we got 3 out of 100 patients who decided not to have surgery following that process, we would actually break even, and that's without the graft costs. And many of these grafts in a tertiary referral centre like Guy's and St Thomas's will cost upwards of £35,000. But actually, we were seeing 25% of patients electing not to have that surgical procedure. So significant cost savings from a pathway reorganisation and a multidisciplinary representation at what had traditionally been a kind of X-ray meeting MDT. It's always important to look at negative literature or studies that have shown it doesn't work, because we often get good information from them. But actually, lots of the issues with some of this negative work that has been published from the UK and elsewhere is that there hasn't always been fidelity to that process of CGA. So there's been a lot of focus in some of these studies on assessing patients and sticking a load of risk scores in, but they're never doing anything about it. So saying you're very risky because you've got terrible COPD, but not then trying to make that COPD better, or indeed saying you shouldn't be having this procedure, or you've got heart failure, but we're not going to treat it. We're going to send you off into the ether to a heart failure pathway, and then you get lost in the process and never have your surgery. So no fidelity to that process of assessment and optimization and decision making with a patient. Or perhaps it's about the timeline to surgery the CGA was done on the morning of surgery, as opposed to further back in the pathway, or often because studies are underpowered. Just worth a touch on prehabilitation. So you'll see from our what do we do in our CGA slide from a little bit back, but lots of involvement from therapy colleagues, with 1 in 4 patients having either an exercise prescription or going through a prehab type process. Prehab absolutely will improve physiological outcomes, and we see that really clearly from the literature. And certainly none of us would want to deter our patients from getting thinner, stopping smoking, doing sport. That's all very good. But it's very important when we're talking about multi-morbid and frail older people that we must badge that under an umbrella of medical optimization. Because people who haven't had their anemias optimized or haven't got decent analgesia for other problems like lower limb disease or hip arthritis can't go out and do exercise. And people with decompensated heart failure can't exercise until you've offloaded them and improved things. So we think very much that whilst prehab is excellent, it must sit under an umbrella that recognises that frailty and multimorbidity are the prime issues for this population. So with that background and with some of the work that we've tried to do locally, where does that leave us? We know that we've got definitely an ageing surgical population, with every study you see increasing numbers coming through. We certainly know that we haven't always aligned our pathway to the complex needs of those patients, and we definitely want to do better. But we know that 2/3 of our hospital beds are filled with people aged over 65, and you cannot have Dr. Williams everywhere doing everything. So we're going to have to think a little bit more creatively about how we try to meet the needs of these patients with the evidence base we have, in order to try and streamline pathways to improve outcomes and make the right decisions with our patients. So I'll let Jagdeep take over with all the solutions at that point.
Jude. So I think are we doing on here? Yeah. So just before we move on to that, I just do want you to kind of focus in on the stats down there in the box as well, because whilst we're talking about perioperative care, this is about something that's really relevant on a system kind of level. And some of the really important stats here are the fact that 2 out of 3 beds are occupied by people aged over 65. That 1 in 3 people in hospital today, if we exclude paediatrics and obstetrics, are in the last year of their lives. And that's data from across Scotland. So that does kind of reframe the way that we need to think about how we're delivering care and what that care needs to look like, whether you work in surgery, anaesthetics, oncology, or any other of the other specialties here at the hospital. But so Jude's kind of provided a compelling argument around, why we need to adapt our services, what we need to do differently, the evidence that there is to support transformation in care. But then the question arises, how do we actually start to get this working out there across our hospitals up and down the country? And of course, things have really changed over the last 22 years since we've kind of first started working in POCs at GSTT. And, there have been lots of positive moves forward. And some of this is around the fact that actually we do have data available to us in different ways now compared to 22 years ago. But it's up to us to make sure that we're collecting the right data and that we're sharing that data effectively between primary and secondary care. And just this morning, we've been having a discussion about how we can start to get some of those processes embedded within the health board here in Fife to be able to get data from primary care flowing into the perioperative setting. But, of course, until we're able to get that data coming in, describing the population, telling us how frail they are, how cognitively impaired they are, how many meds they use, how many long-term conditions they have, we've also at the same time got to make sure that we're putting in effective screening here within the hospital kind of walls as well. And when it comes to effective screening, of course, that's got to match today's healthcare user population. So if kind of the majority of people coming into our services are older, then we've got to screen for the things that put them at risk of adverse outcome. And we know that those things are frailty, cognitive impairment, polypharmacy, and multiple long-term conditions. So if people are coming in through the emergency department, they need to have triple assessment at the front door with NEWS, CFS, and 4AT. If they're coming in through our elective pathways, those pro formas, clerking sheets that we all use need to include these metrics in those clerking sheets. So that's the first bit. But we also need to work with our patients better as well. So we've got lots of resources to help to explain to patients what they can do to get the best outcomes for themselves from any surgical intervention. And lots of those resources exist at the Centre for Perioperative Care. So have a look at that website, at the British Geriatric Society. It's really helpful putting up posters around the hospital explaining to patients what frailty is, what they should expect, kind of when they're encountering any healthcare professional. But also kind of making sure that our clinic letters explain to patients what's going to happen when they come in at the front door. So we've got leaflets when patients come to our POPS clinics explaining how we will assess them holistically, that this is just the start of the journey around deciding whether surgery is the right thing for them or not, and sending them out a shared decision-making leaflet so they can start to think about what is it that matters to them, what is kind of the outcome that they want from that intervention, so that they can then have a meaningful conversation in clinic. But it's also about staff awareness, and it's about all of us recognising kind of the value that we all add along that perioperative pathway. And often we have the feeling that we just don't have enough time to delve into these things, and therefore, you know, do we really want to open that conversation about someone's physical activity or their smoking or their alcohol? But our GP colleagues have got amazing kind of approaches to this. So they've got things like Make Every Contact Count, which is 1 minute interventions, so brief interventions that they use with patients, evidence-based, that allow the opening at least of that conversation to then think about where we go next, and supporting them with that. But also about kind of making sure that our staff know that if someone does score on a cognitive assessment tool, that they may be at risk of delirium, making sure that we've got delirium guidelines and that everybody is sharing those from the very first moment, and giving patients leaflets about the risk of delirium, what that might mean, what it might look like, what families and members of their carers can do to support them. But of course, this is also about acknowledging where you need to have additional expertise. And that's why it's brilliant to kind of hear about kind of the work that Duncan's doing with the high-risk anaesthetic clinic, where we can make sure that patients who've had previous anaesthetic issues, anaphylactic issues, airway issues, single kind of condition issues like myasthenia that might affect somebody's kind of the approach that we take to anaesthetic for that patient, that they are then accessing that relevant expertise early in the pathway. But also recognising when do we need to refer to a geriatrician to be able to support a patient living with those geriatric syndromes that Jude was describing. And so we've got kind of posters and things that we've got up in all of our surgical clinics, kind of supporting surgeons to know when they should refer patients to a high-risk anaesthetic clinic and when they should refer to a POPS clinic. And we try to make sure that patients don't get referred to both, because we don't want them going off to one clinic and then coming to another one, but it's about trying to make sure that we're triaging to the right place as early in the pathway as possible. And so then that then leads into the model that Jude was describing. So the POPS model, which works for the elective pathway, but also for the emergency pathway. So through our service, we see between 1,800 to 2,000 new patients a year across the different surgical subspecialties. And then we see another 3,000 emergency admissions. Because we're there on the wards, co-managing patients with the surgeons, we're able to then pick up people every morning who have come in overnight as an emergency, who would benefit from our input. And it's really interesting looking at the data around this, because generally when you kind of think about people coming in under the emergency general surgical team, then you normally think, well, they're going to get surgery. But actually it's about 40% of the EGS take that goes on to have a procedure during that index admission. So 60% are essentially being medically managed on a surgical ward. And even out of that 40%, well, 15% altogether have surgery within the first 48 hours. So a lot of it isn't as emergency as we sometimes have the feeling it is when you really look at the data. And there is time to intervene during that initial 24 to 48 hours, as we've been doing in hip fracture for many years. So that's kind of fine at Guy's and St Thomas's. We're pretty shiny. You know, we've got our lovely hospital at Guy's at London Bridge, at kind of St Thomas's opposite Westminster. We do have a lot more resource, both workforce and financially, compared to the rest of the country. And we're very well aware of how lucky kind of our organisation is. So when we looked at this around about kind of back in 2014 or so, we found that there are only 3 hospitals around the country delivering POPs type services for older patients. And so when we explored that a bit more with those teams, kind of, you know, they didn't tell us anything particularly surprising, but they said, look, we don't have the money, we don't have the workforce that you guys have, so we can't do this at our hospital down the road or across the country. And that was a bit of a kind of challenge to us at GSTT, because of course, whilst we want to deliver really kind of high quality services to our local population, we want to deliver equitable care across the NHS. I mean, that's a fundamental kind of premise of the NHS. And to do that, we had to do some work kind of exploring, you know, what our healthcare professionals think about this. And so, you know, whilst we do lots of co-production with patients and their carers and their families and understanding what they want from the service, sometimes we forget to work with healthcare professionals to understand, you know, what is it that they actually need support with. And so some of this work kind of that we've done with surgical trainees, with anaesthetists, with general practitioners, helped us to start to work out who could add value along the pathway and what did we need to support them to be able to do that. And that's what really helped us to kind of recognise that we do need to refashion the workforce that we have. We're not going to get a kind of a whole load more training numbers. We're not going to get a whole load more consultants or nurses or practitioners. So we need to think about how we support our workforce to develop the skills that they need to address today's healthcare users. And so that's why we've developed kind of curricular competency frameworks, e-learning modules for nurses, allied health professionals. We've set up perioperative foundation programs, which Dr. Rogerson, who's just started here, kind of worked on the surgical trainees kind of surveys and also the anaesthetic and the GP one in the background, but also evaluating foundation programs. So, you know, do kind of those programs really support our junior doctors to develop the skills that they need for the future. But also specialist training programs, come and work with us for a year, develop those skills as part of a fellowship to then go off and set up services elsewhere. And that's supported through lots of e-learning modules and conferences and so on as well. And it's a similar issue around the money, because as much as we want more workforce and we want more money, that's unlikely to be coming anytime soon either. So this is about refashioning what we've got and thinking about where we move money around to be able to deliver quality care. And these were some of the kinds of metrics that different teams who've then gone on to set up POPs have used to be able to illustrate how these are cost-saving approaches, as Jude showed through the academic literature, but then we also need to be able to show that on the shop floor as well. And that's been really nice, kind of working with different teams across the country, showing how different teams have used different approaches to show how they are making cost savings. Some places looking at a reduction in readmissions, in other places looking at medicines optimization and reducing drug bills, in other places looking at reductions in med-reg call-outs to surgical wards, releasing them to be able to work at the front door where they can actually support admission avoidance and get flow better through the hospital. So lots of different centres looking at lots of different metrics to demonstrate how this brings organisational benefit. So that kind of had some impact. So when we looked at it, you know, just developing those resources for the workforce, illustrating the cost savings, and then looking again 5 years later to see whether this had actually resulted in uptake of these services, showed that there were more hospitals taking up POPs type services. But what it also showed us was that it's not just the money or the workforce. This is the issue here of implementing change. We've had long held traditions of patients being medical patients or being surgical patients. And so actually there's something about the cultural change that needs to happen to be able to start to think about this from a patient focused point of view rather than a specialty focused point of view. And so that's led on to further work with various kind of people, particularly from an implementation science point of view, that helped us to work out what was it that really needed to happen to be able to implement POP services. What were the core components of these types of services that you absolutely had to do? And then what were the things that you could change according to your local context? And then working with other teams across the country helped us to work out what those shop floor clinicians needed to be able to embed this in their local hospital. And that helped us to get to this point, which is this is what kind of teams around the country have shown us that they need to be able to start their journey on a POPs kind of program. So they need the physical resources. They need to know, what they don't need to do is spend their Saturday mornings writing yet another kind of example of a pro forma or a guideline or a pathway or standard texts. So they want all of those resources on a website where they can just go and pick it up, adapt it to their local context, but not have to start with a completely fresh kind of page. So we've made all of those available through a NHS website, Futures, which all NHS clinicians with NHS emails can have free access to. So it includes our clinical resources, it includes sample business cases, job descriptions, job adverts. We're slowly adding on now education and training resources, so things like slide sets about frailty, about delirium. So again, people don't have to every time start with another new slide set. But it also allows sharing of best practice. So we've got a whole list of people around the country who kind of say, actually, I'm happy to be contacted to understand how we've set up a pharmacy service at Wrexham, how we've employed advanced nurse practitioners in Yeovil and down in Exeter, how intensive care doctors have taken on these roles rather than necessarily needing to be a geriatrician. But what also came through very clearly was that teams needed to have some quality improvement support. So whilst their local QI transformation teams were really helpful, they needed some expertise around perioperative care services. And that's where the NHS Select team then support with a 6-month programme where you have one individual, so for here it's Mandy, who's working with Duncan and Andy and Marie, to be able to set up the kind of appropriate support that's needed to implement this type of change, alongside the measurement support, which is what metrics do we collect? How do we collect them? How do we make them visible and present them to the board and get the funding and the moving around of money that we need? And that's the website, which kind of everybody can have access to. So either email Duncan, Andy, Marie, or us, and we can make sure that you have access to that. And so what you'll have seen throughout kind of the slide set that Jude's kind of started with is lots of photos of lots of people. And we just wanted to reiterate that pretty much all of those individuals were full-time clinicians who are supporting the research programme that we've been delivering through the POPs kind of programme at GSCT over the last 20 years. And we've delivered most of that with only £500,000. So that's been, a pretty big research programme delivered predominantly by shop floor clinicians. And we think that that's actually what's made it really successful, because it's people who are down on the ground doing this day to day, who understand the challenges and can come up with some clinically meaningful research that can then translate into day-to-day practice. But we have finally now got some money. So we decided not to be a cheap date anymore, but actually get some money to do some work. And so we're now evaluating whether using this programme helps us to embed these kinds of services across the country helps us to embed them, but that they are also clinically and cost effective. And these are the sites. So these were some of our feasibility pilot sites, cohorts 1, 2, 3, 4, done pretty much without any money, nice spread across the country. And now, as part of the study, the green dots kind of popping up there, and then the yellow kind of into our second cohort in the study. And we're really, really pleased that we've got so many up in Scotland here. So this week we've been to Aberdeen, Dundee, and today here in Fife, and we'll be over at Haremyres tomorrow, but all the way down to Plymouth and including Northern Ireland and Wales as well. So this is a four-nation approach that we want to take, which is kind of pretty close to our hearts as being completely NHS committed clinicians, but also, of course, for me as kind of president of the BGS, we absolutely want to have a kind of four-nation multidisciplinary approach to the work that we do. So hopefully those last kind of 40 minutes or so have illustrated that, of course, this kind of work comes with very many challenges, but the benefits are huge and across the system. This really does deliver against that agenda of realistic medicine. It helps us to develop and retain a flexible workforce who enjoy work and get job satisfaction from what they do day to day. It integrates care from primary, community and secondary care services and across disciplines and specialties. And it's about using our money well. As Jude said, this is the taxpayers' money, and we do have kind of an onus to use that money well and deliver kind of what it should be delivering for patients. And it delivers against those local issues, which will be different here in Fife compared to us down in London. But it does also deliver against the political drivers. So if you are chatting to your MPs, and certainly coming up to the Scottish elections now, this is the kind of stuff that will deliver against those three political shifts of disease to prevention, hospital to community, and analog to digital. But it also delivers against national standards, national audits. So it brings kudos to your hospital if you're meeting those standards, and probably brings some financial incentives as well. But most importantly, it helps us to develop the workforce for the future and ensure a relevant research agenda. Hopefully you kind of really got from the presentation that we really do think that this is about it being a team sport. It's about being multidisciplinary across organisations, a four-nation approach, a team sport here locally for you guys working across all of the different teams that input into this, but also, of course, a team sport nationally, where we can help and support, share resources, and many of the websites and things are listed there. And we're always very happy to be contacted directly if there are particular questions that are arising. So I'm going to stop there, but we're always really happy to take questions and certainly challenge, because that's often the important thing, is to have honest questions where we really hear about, what is difficult out there, so we can think harder about what we can do to support you. Thank you.
Well, thank you very much, both of you. That was very interesting, informative. I've written lots of notes all morning. Thanks again. So any questions from anyone in the room or online? And I am now paying attention to the chat, which I wasn't before, and I should have been when the sound went off. Any comments, questions? Okay, Robert first. Sorry, Gav. It was Gav. You go first, Robert.
How do you manage to convince your colleagues that not proceeding with an operation 5% of the time is the right thing to do?
So I don't think they need convincing. I think we're behind you with the realistic medicine agenda. And we were saying earlier when we were talking to the board that healthcare shouldn't be a buffet or a shop where a patient turns up and says, oh, I'd like this and that, but I don't want that bit. We are expert and know the literature and have years of experience in knowing what happens to people when we do certain things to them. So if we're doing our job well, what we're doing is presenting patients with realistic choice, as we know from your realistic choice agenda, and then patients get to put their values and their wishes and what's important to them into that realistic choice. And so I think working with surgeons and anaesthetists over the years, just as we would if we were counselling a patient on taking a statin or an antihypertensive, what we do is we present realistic choice, and then people say, no, thanks, don't fancy that, or thank you very much, I appreciate the risks, but I think if you think it's a reasonable idea, we can go with it. So I think you can't, if you haven't worked together, immediately have that kind of working relationship. You've got to build up trust. You've got to be data driven. And, we absolutely evaluated that with fresh eyes. So what happens to patients at 12 months when they haven't had an operation? Because if they're all dying of their ruptures, perhaps we've got it wrong and perhaps we're shortening their lives and we're not doing it well. And so using that data and using that common working to have proper conversations with people about what we think will happen, so then they can choose from a realistic option.
Are you happy, Robert?
Okay.
Just for everyone. Gavin.
Thank you very much. And I think pragmatically making these decisions about other patients is absolutely the right thing to do. And it's obviously difficult if you don't have evidence and the infrastructure, and this kind of backs that kind of up. I was talking with Duncan and colleagues last week when we were talking about some of this, and looking at all the interventions. There was 14 interventions that were kind of outlining things that we should be doing in a perioperative situation, an analysis of these patients that are going for surgery. You look at about 10 out of 14 of them. Arguably, we should be applying them to all patients, whether they're having surgery or not. And I know it would be pragmatic about our resources and money in the NHS to be able to roll this out to all patients. 10 out of 14 of them probably benefit all patients who are frail. We're using surgery as a trigger to apply that lens at that point, which I think is a good way of doing it. But arguably, it's just a small part of the whole population that might benefit from all of these interventions.
Yeah, no, that's exactly right. And we were having that conversation earlier with other team members, was that it is exactly the same approach that we should be applying across kind of our healthcare systems for the reasons that you've just described. And of course, now with this work underway, we're finding that our renal colleagues are coming to us and saying, can you help us with decision making around dialysis and transplant? Because we're also encountering exactly the same population there. Similarly, within the cancer setting, about oncological treatments as well. And that's why it's so important, a couple of things. One is getting the processes right so that we are identifying people living with these kinds of conditions as early in the pathway as possible. So embedding that screening approach as soon as they're entering into secondary care. So we know, on a day-to-day basis, we should know how many people aged over 65 living with frailty, multiple long-term conditions, polypharmacy are coming into secondary care. So then we can align our services according to that population. So absolutely, it's applicable across so many different settings. But then that also raises the issue around education and training, because we need to support people to be able to screen effectively, but then also do something about it. As Jude was saying, so much of the CGA literature which says, oh, it doesn't work, is because all they did was assess someone, but then they didn't do anything about it. So it's about then working out what can you do for that individual to optimize them, diagnose and optimize, but also then support that shared decision making about whether an intervention is the right thing or not. So there's the wider education and training issue. And there are, again, lots of resources. So we've got frailty learning modules tier 1, 2 and 3 available free of charge through the BGS that everybody should be really working in healthcare should be up to speed with. So there's the education and training side of things, and then there is the structure of clinical services. How do we get collaborative working, co-management of patients, bringing in the right expertise at the right time for the relevant patient? As geriatricians, we don't want to see people who aren't complex. That's not where we add value. That can be done by lots of different people. But where we add value is when we've got people living with those multiple long-term conditions, frailty, dementia, the interface between physical and mental health, health and social care, and the complexity with which they present. So it's making sure we're aligning our skills to the right place as well.
Any other questions? Sorry, I don't know your name.
So yeah, I think you do, don't you? I mean, things are never set in stone, and just as with birth plans, and we know with advanced care planning, people are allowed to change their minds, and people panic at times of healthcare crisis and things. So I think that we can all think of examples where that's happened, and that's not always been a bad thing. That's actually been an evolution of an understanding of a disease and a professional patient relationship. But in the main, it doesn't happen. And part of the reason I think it doesn't happen is that there are, it's just as CGA prompts optimization. So does that process of deciding perhaps surgery isn't right for me, then prompts advanced care planning and treatment escalation planning and discussions about preferred place of care or what might happen if my disease worsens. Can we build in community support so that you won't be bleeding from your cancer, or so that you know what to do if you get pain in the middle of the night, or that kind of thing. So I think it does happen, and that's not always bad. But I think in the main, a decision should trigger the next stage. You're not saying we're not going to do anything. You're saying we're going to manage this palliatively or conservatively or medically.
Any other questions? Neil?
Just to add on to Eleanor's question, how often in your experience do people not necessarily decide not to proceed with surgery, but decide to look at other options or decide to wait and see what happens in terms of getting symptomatic relief if the symptoms become less tolerable?
Yeah, I think that happens as well, doesn't it? And we in the main run in our elective service run a kind of one-stop shop. But it's not that, if we've seen you once, we won't see you again. And so we do have patients where we build in, future appointments to say, this is a bit difficult now, you've got other things going on, but maybe we should review this in 6 months or that kind of thing. And, the common example is patients with aortic aneurysms who are getting towards threshold and don't know whether not driving is going to be a real thing for them. So things like that, external things that are important to patients feeding into decision making that we may well review in the future.
That's why it's really great to work with your GPs as well, and kind of make sure that you're getting communication is so kind of key to all of this, isn't it? And making sure you're sending out the right information, giving kind of clear options to the GP as well. So if the patient does go to the GP and says, what do I do now? Because I've got hematuria related to my bladder cancer and I'm really struggling with this, what are the options? So that they've also got something that they can then offer the patient and have a route back in. Because we don't want to unnecessarily build in follow-up appointments, because that's again down to kind of making sure we're using our slots effectively, but we've given the GP and the patient the kind of right route back in if needed.
But to Robert quickly, he had his hand up, Duncan. You and Ethicus are asking so many questions.
We do conversations, patients for vascular surgery, seems more cancer. Is there not really find there's a distinction between either, or?
I don't think so massively. I mean, that's a sort of anecdotal experience answer. I don't think so massively, actually. I think the timelines can be a little more fraught with cancer because, you're on that quick 2-week wait thing, aren't you? So that's often a little bit harder to kind of build rapport in that short time frame. But I think if we look at some of that data that I briefly skimmed over earlier, which is where we looked at 7 other POP centres across the UK and what they were doing with turned down cases, actually some of them were purely doing cancer work and actually had a slightly higher rate of turn down than we do at Guy's and St Thomas's. So I think from the limited literature we have, that anecdotal feels probably reasonable. I think just one last point. So I think it's just really important that I don't want this to be viewed as a turn down service. So we absolutely want to be operating on the right people at the right point, but we absolutely also have conversations with surgeons and anaesthetists where we say, look, they're so much better now. We treated X, Y, and Z. They'd really benefit from this. Will you consider them? So it's not always a turn down.
Duncan.
Balancing measures in our settings about people who decide not to go ahead with something. So the example was hernia. So and then there's a 2% per annum incarceration risk. So have you got any data to share or any experience to share about what the outcomes for those sorts of patients are in terms of representing as an emergency cost that then might get done at the front door? How you stop that happening? You safety net that?
So we probably don't have any local data on that, Duncan, but some of the data that's kind of looked at acute emergency presentations has shown that for the 5 most common abdominal emergency surgical presentations, that the kind of frail older population who did present acutely did just as well, if not better, with conservative management and had more days alive and out of hospital at a year than those who underwent surgery. So there is some international kind of data that we could kind of draw kind of from for that. But it is interesting, isn't it, those kind of stats kind of that you just kind of said there, which is similar to the aortic aneurysm stats, that if you've got a 6 centimetre aneurysm, you've got a 3% chance of rupture. And yet often patients kind of think they've got a ticking time bomb. But actually, 97 out of 100 aren't going to rupture in that year. So there is just something about the way that you end up framing those conversations that changes kind of the way that you're ending up the decisions that you reach together as well. So, and I think, the other thing that you kind of raised there really is that, of course, we just don't have this data. And it's just unbelievable that in this day and age, we just don't have natural history kind of data for so many of these patients, particularly the ones who don't have surgery. So all of this data has to get put into national studies so we can see what happens with and without intervention. And that's where we've seen so much of the advances, haven't we, in cardiology, for example, where we've seen that best medical therapy can often be just as good as doing a primary stent. So that's why we need this kind of data to be able to help us to work out who should and shouldn't go ahead with these kinds of interventions.
Sorry.
You've got 30 seconds max.
It should be quick. Based on that point, one of the challenges I often find is being able to communicate that when I don't have the ability as an anaesthetist to understand the natural history of abdominal cancer, kidney cancer, all these other things that we might be getting operations for, to then say your risk is very high, your risk of your cancer over the next 5 years is, and it can often be very difficult because there isn't that data and there isn't that interest necessarily in that data voice from our surgical colleagues to be able to communicate that to patients. How do you address that?
So I think the first thing is to address it with honesty. So I think the first thing is to tell the patient kind of, in this scenario, we don't have kind of clear-cut data to be able to help us to be able to make a decision. And then it's drawing on the data that we do have. And so looking at, for example, kind of data around prognosis with cognitive impairment or with frailty or a particular multiple long-term condition that the patient might have. So often you do have data for the other conditions affecting that individual patient. But there is a lot of, we spend a lot of time on our phones looking stuff up constantly, working across all of these different surgical subspecialties. We don't know exactly what the outcome is for this type of cancer in this type of population. So there is a lot of continual learning kind of every day, looking stuff up. We have a WhatsApp group that Dr. Rogerson seems to have stayed on for the last 5 or 6 years as well, moving internationally, where we kind of constantly put on the papers that we've read that day, like, oh God, I got asked about this, I didn't know, I looked it up, this is the only relevant thing that I can find. And of course, it's also picking up the phone to our surgical colleagues, oncological colleagues, kind of, others in the hospital saying, what would you do in this situation? So there's a lot of shared learning constantly around that.
Well, thank you very much. I think we've got a lot to think about, a lot to progress here locally. And thanks again for coming. Thank you.